It's very important. Why? Because I want to be able to have all that information. I can now use the cloud and come up with ways to figure out who's going to get breast cancer, who's going to get diabetes, and I can predict and prevent. Okay? So keep that thought in mind. Okay, so we're not really there yet, and this is where a lot of people get hung up, is that we're kind of in the straddle between one system and another system, and it's total chaos. Nobody's happy. Doctors aren't happy, insurance companies aren't happy, hospitals are losing money or consolidating. It's chaos. The only people that are happy is me, because I'm a consultant. And I get to go out and tell people what to do next week in Pittsburgh and then leave. It's a good job if you can get it. Okay, so why is it so expensive? Oh my goodness, economic-wide inflation from 1960 to 2010, hospital price growth. Look at that. Hospital prices, medical prices are going out of control. Anybody here really into Adam Smith markets and people like Newt Gingrich, other folks, Paul Ryan, say just let the market do it. Forget all this government stuff. Just let the market do it. Well, we don't have a very perfect market if you know economics in healthcare. Why? Here's Philadelphia. That's where we live. Very few people in this audience are old enough to have had a colonoscopy. I've had 3. I'm 67 years old. Okay, but if you look at this, each bar here is a different hospital in Philadelphia. If you go to this hospital, you get charged less than $1,000 for a colonoscopy. If you go to this one, it's almost $4,000. There's a 5 times difference between different places. That's unsustainable, right? Come on in, sit down. I've already given the answers to about 10% of the quiz, so you're in trouble. But this is unsustainable, and you can see in other places it's the same thing. So we don't have a good market. So you can't, I really don't think you can just say, just have a market, private way to deal with it. We can have that argument later over wine or whatever if you want. Okay, so that's number one, why your job is going to be totally different than mine is cost. They're not going to just be spending money on Medicare and Medicaid the way they did in the past. They're going to grade you by name, and you're going to get a report card for cost and quality. My wife, Dr. Ann Steiner, OBGYN professor at Penn, on Medicare data, it comes out, it says and it's from 0 to 100, 0 is bad, 100 is good. She'll get I'm not going to tell you what her score was, but it was good. And that's transparently available to everybody. Okay, so that's real different, holding people accountable by name for cost and quality. Questions on that? Anybody want to argue that we spend too much money and don't get a good, is there any Barry Goldwater conservatives that really, I'd be happy to mix it up with you.
So
yes?
Those report cards are available for the patients?
Absolutely, on a website. Nobody looks at them, but they're just, that's relatively new, but brand new, yeah. Hospital.gov, you can go and look at those things. Yeah?
Well, how does it come into play with doctors and liability in terms of if they're going to, cut down on the cost, and maybe they would say, we don't need to do 5 tests on this patient because really we probably only need 3, but they're only doing, let's say, 5 because they're covering.
But then they get sued.
Liability.
They get sued. Okay, yeah,
So
but, yeah.
we wanted them to be cost effective, but they also have that concern too.
Yeah, absolutely. Doctors hate this kind of stuff about getting a report card. But actually, for the first time, all of the doctor societies, the American College of OBGYN, the American College of Internal Medicine, Family Practice, have actually come up for the first time and said, we're doing a lot of stuff that we shouldn't be doing. It's called the Choosing Wisely campaign. So every society has picked at least 5 things that they say, we've been doing a lot of stuff we shouldn't be doing, and both doctors and patients shouldn't be doing that. Having said that, that's still a tremendous psychological concern of physicians. Now, what's interesting is the orthopedic surgeons pick things that really affect the income of the radiologist, not the income. We still do over 100,000 knee operations that have been clearly shown to be useless. We do. They actually did a peer-reviewed article where they did a sham thing, where on some people they actually opened it up but did nothing. On the other, they did the actual procedure. The outcomes were exactly the same. So yeah, but again, my waste is your income, and orthopedic surgeons don't want to have less money. Yeah?
I wanted to ask because I saw a video on Vox News, on...
VOX.
Yeah, VOX, yeah.
Fox is okay too. I mean, it's,
But well, specifically on that one, and the man just did this video that his wife went to give labor, and so he wanted to, like, weeks beforehand, he wanted to call and be like, oh, how much is it gonna cost for me?
and they couldn't find out.
And they couldn't find in many hospitals.
Absolutely.
So I just wanted to ask, how is that legal, or because like you can't even really tell.
You
with
can't.
procedure
You can't shop. You can't shop in healthcare.
exactly. How does that work?
It's a big mess, is what it is. And so I can tell you, I actually just looked at this. An appendectomy in this area, Delaware Valley, it costs anywhere from $4,000 to $32,000. The $4,000 is someone like Professor Russo, who has really good insurance, I'm assuming.
Yes.
And the $32,000 is the gardener who has no insurance and may well be illegal. And they go after him. So there's a great study out of Iowa. A graduate student called around 120 hospitals and said, made up a story. He said, Grandma's 62, not old enough for Medicare. Grandma's got tons of money. She's been to 2 doctors. She needs a hip. How much? We want to come to your place. She'll pay cash. 20% of the hospitals said, we have no idea. The ones that said that they quoted a price was $11,000 to $120,000. So, and it's because it's what insurance you have, it's what deal they've, it's a total mess. So you really can't shop for health care the way I just go to Costco and get my tires and my clothes, and I'm not that well dressed, but go to Costco. But you can't do that in health care. It is a huge mess. So it's a great question. Okay, so I don't really want to get totally into Obamacare other than we can, but it's kind of like a 3-legged stool. So there's stuff that the insurance companies have to do, there's stuff that citizens have to do, there's stuff the government has to do, and it works pretty well, and it's still working pretty well. Was it something I said? No. See you later. But one of the problems now is that the Trump administration, which hates Obamacare, has taken away the individual mandate, which says you have to have insurance, so that wobbles. They've taken away the essential health benefits, so that wobbles. And they've taken away the cost-sharing reductions. So it's still working, but it's not working very well because Trump philosophically doesn't want it. Okay, so we can talk about that later as much as you want. But what I really want to talk about now is, I'll say, cost is a big thing that's going to change your lives if you become doctors and nurses and respiratory therapists. Population health is going to change your life. So this is the social ecological model of staying healthy, being good. It's what you do as a person, it's your family and community networks, it's where you live and work, and it's broad conditions and policies. So what do I mean by that? Danny, Louise has a big budget. She gave me a ton of money to go do genetic testing and things on Danny, just for this audience here. So whether Danny stays alive and doesn't have a premature death is based on these things, okay? Whether he has good health care, good doctors, good nurses, good hospitals, is only 10% of whether Danny's going to live a long time. 10%. So all the stuff we're talking about, even if we fix everything, there's 90% of whether Danny stays alive. How old are you, Danny? 21. So he's supposed to live to be 80 now. So, this is a big deal. So, Danny, are your parents Homo sapiens? They are. So Danny has genetic predispositions because of who his mom and dad are, right? That's 30% of whether Danny. Did you grow up near a coal mine or a toxic waste dump? I did not. He did not. So environmental exposure is only 5%. I don't want to embarrass him, but social circumstances. Do you have any friends? Yeah, a couple friends. Okay. It's been shown, seriously, it's been shown if you are socially isolated, if you are lonely, you are much more likely, twice as likely to die of the same heart attack than if you have lots of friends, like Yasmin. If you have lots of friends, you don't die from the same heart attack. Are you with me? So actually loneliness is probably, the Surgeon General is talking about loneliness as an actual big deal. So if you go to synagogue, if you go to church, if you have friends, you're much more likely to do well. Social circumstances. And then there's all this crazy stuff about viral contagions. So whether or not a friend of you smokes will determine whether you smoke. Whether a friend of you is fat, people actually get sick because of who they hang out with. And that's pretty weird and pretty neat. Okay, so social circumstances is 15%. Behavioral patterns, do you walk? Do you eat right? Do you eat the Mediterranean diet? Do you use a condom? Are you a drug addict? Blah, 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 okay? So what this says is, wow, we spend all our money on hospitals and doctors, and yet that's only 10% of the pie of these social determinants of health. That's the big population health buzzword, social determinants of health. So what people like me say is that this is downstream and we spend all our money here, but this is upstream from here to here to here to here to here, and we probably should be spending more money on these kind of things. There's a guy in Camden, New Jersey, right across the bridge, who has discovered, a family practitioner who has discovered that he now really spends most of his time on housing, food, and getting people to church or synagogue or someplace. So keep that in mind. Okay, so that's a big deal about population health, working upstream. We just talked about that. So this is what I'm talking about. Here's some data to say I'm not just making this up. So if you look at this here, map D, red indicates the lowest social to health spending ratio. So in these states, they don't spend money on social workers, on food for people, on food deserts, on sidewalks, on stuff like that, okay? And if you look at then lung cancer mortality rate per 100,000, it looks almost identical. Wow. Are you with me? That's not doctors, that's not drugs, that's not whether you go to HUP or whether you go to Mount St. Elsewhere, right? Same thing. Percent of the adult population that's, that's obese, almost identical. Percent of the adults who reported 14 or more days in the last 30 days is mentally unhealthy, which always cracks me up is that Nevada pops up. Go to Las Vegas, have a good time. Okay, so does that show you something about working upstream and not just in hospitals and doctors' offices and whatever? So population health, and that's tied into that deal, value-based payments. So we talked about value-based payments somewhere here. Yep. So basically, if I get a big chunk of money to take care of 1 million people, I should be doing those nutrition, housing, spirituality stuff, right? If I want to prevent people from going to the hospital. Because what I didn't say here, which I should have said, was right here under the old system that I love, you want your hospital filled to the brim as much as possible, doing as many surgeries and CT scans and labs as you can, because you get money on every single one, right? Whoa, great. Under this, the new world, you want your hospital empty. Why? Because you got a big lump sum of money and you can spend it any way you want. Every time you have a surgery or a CT scan, that's money out of the organization's pocket that it could use to build a new ER, to give you a raise, blah, blah, blah. That's huge. Are you with me? Big deal. Okay, so population health is big deal. So I love this map. This is Philadelphia. You should know and love this. This is down where the Ritz theaters are in the old town, right? Nobody goes to Ritz theaters down? All the foreign films? What's wrong with you people? If you're born today down by where the Liberty Bell is, that baby will live to be 88 years. Are you with me? If you're born 3 miles away in zip code 19132, that baby will live 20 years less. That's a big deal. Are you with me? That's huge. Why? Whoa. Why? There's no grocery stores. There's no sidewalks. You can get murdered by someone with a gang or, social determinants of health. All the apartments have rats and mites that make your asthma worse, right? Okay, so but this is like right here. I mean, oh, come on. This is, somebody say, wow. Thank you. No, I mean, this is a big deal. Tough crowd. All right. So, the world of your medicine as your doctor, nurse, whatever you're going to become, going to be different because you're going to be held accountable for cost and quality by name. You get a report card. You're not going to like that. You're going to be held accountable for population health, social determinants of health. Suddenly, your medical practice or your hospital is going to have to worry about, is there a grocery store where you can get good food, vegetables or whatever, right? Okay. So what else is going to change? This is going to change your life much more. I said we're going from diagnose and treat. So I was a pathologist. I was the most important doctor because nothing happened until I said it's cancer or it's pneumonia. Diagnosis, then they treat it. In the future, it's going to be predict and prevent. How do we do that? Because we're going to be able to grab data on, well, we already have the data. Amazon and Facebook have the data on you, on me. Amazon knows more about me than my wife does. No doubt about it, okay? So basically, we're going to have data from your social graph, which is that Danny has a couple friends and Yasmin has 100 friends on Facebook or something, okay? So that's going to be something. Biosensors, we're going to take her Fitbit and know exactly how many steps she does every day, and we'll be able to monitor her blood pressure in real time, okay? Not just when you go to the hospital. The new Apple Watch does AFib, right? Totally. Which is going to cause a lot of problems for cardiologists. I was just with some in Dallas a couple days ago. They don't like that. But you're going to get data on each person from their biosensors, from their imaging, their CT scans, what's going on in your liver, what's going on in your kidney. We're going to now know a lot about your genome, right? We're going to have your entire genome. We're going to have your entire RNA, all your proteins, all your metabolites, your microbiome. I didn't learn anything about all the bugs in my gut, and now it turns out the bugs in my gut are helping me get diabetes or not get diabetes, or that the bugs in your gut have a big deal to do. We're just beginning to understand how they affect your health, both for good and for ill, okay? We're going to have data on the way that your DNA is methylated and twisted. So it's not the DNA sequence, it's whether or not there is a methyl group or a histone on there covering up a gene, okay? Is that right? Okay, she's got it. And then this is like whether you live near a coal mine or something, so all the exposures. So all of that gives you a tremendous amount of data about you. Not to mention what songs you like, what emails you're doing, blah, blah, blah. Okay, so all that data is AI predictive analytics, which is such a big deal that people are calling it the fourth industrial revolution. The Industrial Revolution is what changed us from an agricultural society in the 1700s and stuff. And I mean, you guys know that in 1900 in America, the average age of death was 47. 47 years. Now the average age of death is about 80. Women live a little bit longer. So artificial intelligence, big data, and machine learning are general purpose technologies like steam engines and electricity that totally change the world. So there's so big deal is all I'm trying to say. Big, big, huge deal. So how will medicine change when you become doctors and nurses and respiratory therapists and PAs? Sick care is the old world. Wellness or health care is the new world. Diagnose and treat, predict and prevent. Reactive, we don't see you till you come in to see me in the office. Now, we're monitoring her Fitbit. Some nurse or PA somewhere is monitoring everything that's happening with her Fitbit, or eventually her little nano things that she swallowed that are zipping around, going to be able to, you can predict a heart attack a week before we can do it now, because there's certain enzymes come out in the blood before you can get them. But if you have a little nano, don't have this yet, but a little nano thing and zipping around, it's going to say on your cell phone, she's got those things, in a week she'll have a heart attack. You could do something about that before she has her heart attack. Discontinuous versus continuous. Focus on the individual patient. I never see Louise till she comes to see me, and I generate a bill. Versus focus on the population, downstream versus upstream. Okay, so you say, oh yeah, this guy's the typical guy talking about stuff in the future. This is never going to happen. I'll get through medical school and make my money before it happens. Sorry, already happening. So here are things that AI already, and most doctors don't get this. Most hospitals aren't doing this. They're really stupid. Ooh, I'm on camera. Oh. They're not thinking about the things that technology will change. That's better wordsmithing. So AI, artificial intelligence, equals or outperforms physicians in what? Cardiologist level arrhythmia detection with a neural network. Deep learning algorithm for detection of diabetic retinopathy in the fundal photographs. Diagnostic assessment of deep learning algorithms for detection of lymph node metastasis in women with breast cancers. Dermatologist-level classification of skin cancer with deep neural networks. Predicting non-small cell lung cancer prognosis by fully automated microscopic pathology image features. You'll note that it looks like for images and for radiology and pathology, those are some of the first things that we're doing. And we say deep learning, we say machine learning. We're talking about going to the cloud and doing billions and billions of simulations to come up with an answer. Okay, and that's only recently we've had the cloud that we can do that. Are you with me? Before, we didn't have enough computing power to do that. Okay, so Babylon Health is a company in England, and this is the test that everybody has to take in England to become a practicing doctor. Okay, it's kind of the test you have to take. The average passing grade for a human is 72% over the last 5 years. So you get 72%, you can practice medicine in England. You with me? This is a computer chatbot from Babylon Health, received 82%. It outperformed the humans in diagnosing on this test. That should excite you or worry you, or you should say, whoa, that's pretty weird. They're actually now using it in the National Health Service for 26,000 citizens in London that don't have a GP. They have an algorithm on a chat box on a computer. Are you with me? Big deal. Okay, so this is the father of deep learning. So I don't want to get too much into machine learning, deep learning, neural networks. Those are all ways that we can take all that data I was telling you about, the DNA and the RNA and your social life and everything else, and take all that data and crunch it and come up with stuff. Okay, so this guy is a big shot in deep learning. I think if you work as a radiologist, you are like Wile E. Coyote in the cartoon. You've already over the edge of the cliff, but you haven't looked down. There's no ground underneath. It's just completely obvious that in 5 years, deep learning is going to do better than radiologists. Might be 10 years. I said this at a hospital. It did not go down well. In case you didn't spend as much time as I did with Captain Crunch and cartoons on Saturday morning, that's Wile E. Coyote. He's going to go down. Yeah?
With outcomes being the emphasis in the future,
Yeah.
do you think that's going to discourage people from practicing, practitioners working with patients who have like chronic progressive illness, if it's looking at the outcome and the outcomes?
Yeah, I think there's a great, that part of, you know, I'm big on the doctor-patient relationship, that when I go to a doctor, whether they're nice to me actually does help, whether or not you do anything, and in chronic diseases, certainly that's a big deal. We don't know. It's a Wild West. I mean, but basically, I can tell you that as an old fart, you know, the medical students and new doctors today don't know how to diagnose, don't know how to do a physical exam. They really don't. They just order a CT scan. They don't know a lot of stuff that old people like me think are really important. And because laying on the hands does change the relationship between the patient and the doctor. It's huge. I mean, this is big deal, big deal. Yeah, great question. Okay, so it turns out that in October, I have to go to Halifax. I got invited. There's a big meeting of medical school deans that's from all over the world. And the big thing in Halifax, this meeting for these people is, how should AI change the way we teach medical students? So to tell you how bad we are, they asked me to tell them. So that's pretty pathetic if you think about it. But by looking into it, the way we should change medical school education, which probably will affect some of you, maybe, but medical schools are really slow to change, is this. This is a book that just came out. It's saying, look, humans and machines, computers, should be synergistic, not competitive. Humans have to work with algorithms and with this stuff. And there are 8 new fusion skills necessary for successful human and computer optimization. Rehumanizing time, responsible normalizing, judgment integration, ability to decide a course of action when a machine is uncertain what to do. You guys all know what an algorithm is, right? Okay, so there was a guy at Berkeley in Lawrence Livermore lab was trying to buy a book called, it's something about the fly, the anatomy of the fly. It's a biology book that nobody ever looks at, right? So he went on Amazon used books to get one, and he looked, and There was one on there, but it was like for $500,000. What? It's worth 30, 40 bucks at most. The second one was $480,000. What had happened was someone had made an algorithm to have the highest cost for a used book, this book. Someone had an algorithm to have the second high. So basically an algorithm went crazy. But the answer was, so basically they're saying when the black box AI comes up with, that she has prostate cancer, probably women don't have prostates. So probably not true. I mean, that's obviously ridiculous, but. So basically they're just saying that what is the best, down at the bottom here, knowing how best to ask questions of AI across levels of abstraction, working with AI to extend your own capacities, the ability to develop robust mental models. These are all things that probably everybody in work, because AI is going to change work for everybody. I don't know if you guys know, but lawyers, if anybody wants to be a lawyer, in the old days, 10 years ago, when you do discovery in a case, the young lawyers have to go through and read millions of documents. That Michael Cohen guy who's in trouble, who worked for Trump, there were millions of documents about his taxi businesses and stuff. Well, it turns out now that they don't have lawyers do that anymore. They have AI do it. They read all the stuff by the computers, and these are the things you have to look at to get Michael Cohen in prison. So that's changing law work tremendously and changing the job abilities for lawyers. So whether those are right or not, the question is, if you want to be really smart and be successful, you better be thinking about how you're going to be able to use technology not to replace yourself, but to work with it to be the best doctor you can be. Now, because computers can do stuff that we don't do very well. So who's the smartest person in this room? Come on, somebody who's brilliant. It's not me. Come on, come on. Steve, look around. Who's really smart?
This guy.
Him? Okay, so we'll say he's the smartest guy in the room. I find that surprising, having talked to him a little bit, but okay, fair enough. Neuroscience says this guy, what's your name?
Brogan.
Brogan. What kind of name is Brogan? That's Irish. Brogan, okay. Brogan can only keep 6 things in his mind at once. That's it, because he's a Homo sapien, I'm assuming. So he can keep 6 things. Regular people, Louise and me, 4. The dumbest person in the room, 2. Now, when you're admitting someone with diabetic ketoacidosis and hypertensive failure, you're thinking about 38 different things, right? Computers are really good at that, looking at lots and lots of things, okay? Humans are really good at what she's worried about, is actually being nice and making you feel good and blah, blah, blah. Are you a nurse or something?
No.
Oh, okay. Are you a nice person or?
Sometimes.
Okay, good. Just checking. Okay, so is the doctor-patient relationship going to change? Absolutely. My entire 38 years, customer seeks health services when feeling ill, sorts through different care options. Differential diagnosis was always, that I got to be chief resident because I had more differential diagnostic possibilities than other people. Data is then captured from the pathology lab, the most important lab, to confirm the diagnosis that Louise has pneumonia at Lankenau Hospital, and we now know what drug to use, and we cure her. She comes back and can teach. Okay. This is the reality of the new world. Data is captured passively being medical-grade wearables. Patient is being constantly monitored for all this stuff, right? Apple Watch, atrial fib, blah, 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 blah. Okay, so all of that stuff is constantly being going into whether you can predict and prevent what's going to happen to Louise. A provider, nurse, PA, somebody, reaches out and says, Louise, we've been monitoring your blood pressure, and it's usually, 140 over 80, and now it's like 200. Are you stressed? Are you, da-da-da. Totally different. We're reaching out to them like they do with your cat. It's time to, they do better with cats than humans in America. Okay, provider already has historical database of all those relevant biomarkers and genetic predispositions. So, we're not there yet. There was a great article in the New York Times just a couple days ago. So we have 20,000 genes, each of us, because we're humans, right? All of the stuff we're talking about, they've only really studied 5,000 of them. 5,000 genes we know something about. We know a gene for cystic fibrosis, has lots of alleles. We know a gene for Huntington's chorea, right? But 15,000 genes or so we don't don't have a clue what they do. So we're not there yet, because you'd have to know what all those genes do in order to be able to predict and prevent, right? So that's happening, okay. So this is why, even more so, your world's going to be turned upside down. It's what is the Uber for healthcare, okay? Disruption. There's a guy named Clay Christensen who writes a lot of stuff at Harvard Business School about disruption. So disruption is, Kodak was a famous company, okay? Kodak, I had a Kodak camera. Kodak had film. Kodak had all of the abilities to do digital photography, and they didn't do it because they were film. Their whole culture was film, Ektachrome, Kodachrome, da-da-da-da. You can now no longer get Ektachrome or Kodachrome developed. It's gone because digital photography, how many people here have a digital camera? All of you do if you have a cell phone, right? How many people here have a Kodak camera? None of you, because Kodak's bankrupt. So the issue is when you disrupt something, Sony for music, Apple's now a music store, blah, 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 you have new people come in that then take over. I mean, Kodak was the #1 company in the world for a while. It's now gone, right? Okay, so why is healthcare ready for disruption? It's too expensive. Prices vary and are not related to costs. No accountability for outcomes. Since 2000, we showed that inflation has increased 41% for everything. Health benefits have increased 200%. 63% of Yelp ratings for healthcare are 1 star. That's not good. This guy runs a health plan in Texas, and he's a big shot, runs an insurance company in Texas, and his father is 90 years old and got cancer and now has to go to MD Anderson. And so he says, seeing it up close from a patient's point of view has hit me. The system sucks. That's a technical term we use in healthcare economics. In July 2012, the US economy produced same volume of goods and services as in 2007 with 5 million fewer workers. Our jobs are going away because of automation and AI and predictive analytics everywhere, okay? Self-driving cars. Truck drivers will be out of a job soon. From May 2007 to May 2011, the US healthcare system has added over 1 million jobs despite declining admissions and office visit volume. So we have less work to do and we have more people doing it. Not sustainable in an economic system, okay? And it's a big deal because in most of the little hospitals I go to around the country, health systems often are the largest employer in a whole county. Health systems, school systems, I mean, so as you rationalize healthcare and have less people working, what does that mean for the society? What does that mean for the PTA? What does that mean for local restaurants? Big deal. So do you guys know what NPS scores are? Net Promoter Scores? It's a way that companies say how much people like them. It's like customer satisfaction kind of. So the Apple is 89, Google's 50, most healthcare companies are 12. That means people don't, and why would you like us? Why would you like healthcare? Because we're terrible. We make you park, we make you, I mean, has anybody here ever been in the hospital? It's not much fun. And we don't do real, I mean, it's not customer friendly. And oh, she left, but you can't even find out how much it's going to cost if you call ahead of time. So this shows that technology may disrupt healthcare. And like this is $2.7 billion last year in these private equity deals, hedge funds saying, there's a lot of people that need healthcare. If we become the Uber for healthcare, we make money. And that's all they care about. These are terrible people, these hedge funds people, in my opinion. That all they care about is money. And so they're saying, we're going to remake healthcare by developing new tools for consumers, patients, doctors, insurers, hospitals. And Eric Topol's a very famous guy now. There's no shortage of hype. We're in the early stages of learning these tools. Who do they help? Who do they not help? Who do they provide just angst, anxiety, and false positives? So these are all the things that are happening now in healthcare that are driving Jefferson, Penn, Lincoln out crazy. So you've got Amazon, Berkshire Hathaway, JP Morgan Chase. So these guys, you ever heard of Amazon? Yeah, you've heard. No? Okay, yeah, okay, yeah. Where are you from? Guam or, no. So these guys have just come together and they're saying we have 1.2 million employees between all of us. And we just hired Atal Gawande, who's a very famous visionary guy, I know him a little bit, who's going to be the CEO of this. And we're going to now change, we're going to be the Uber for healthcare for our 1.2 million employees and eventually for everybody. Okay. Will it work? Don't know. CVS and Aetna, so a pharmacy company and a pharmacy benefit manager company and an insurance company are merging, okay? Optum, Cleveland Clinic, Oscar, all sorts of things. So all these things are happening that traditionally distinct sectors of care provision, doctors and hospitals and nurses, insurance, Independence Blue Cross, Aetna, and pharmaceutical manufacturing, these distinct sectors are becoming blurred. So let's just look at one, Amazon, Berkshire Hathaway, JP Morgan Chase. They've said that they have 1.1 million employees, and they have more if you include their dependents. It's probably 3 times that much. That's a pretty big chunk of a population to get a prospective payment to take care of that we talked about, okay? They have 300 million active customers on Amazon. He's not one of them. They have 100 million Prime members, like my wife, that go crazy because they get free shipping. They have 5 million sellers on their website, and this is important. Jeff Bezos gets bigger and bigger and bigger because he says, I'll buy Whole Foods, and I don't really care if I make any money on Whole Foods. I want the data from those people. And he makes all of his money on Amazon Web Services. So Google, Amazon Web Services, Microsoft have this computing ability to take all of that data from your social life, from your DNA, from everything you do, and crunch it, and they charge you to use their computers to do the billions and trillions of simulations to come up with the answer. Are you with me? So they can be a lost leader in terms, they can make money if they provide health care and make no money on health care. That makes it hard to compete with them, okay? So as soon as they bought Whole Foods, all the other grocery store companies went crazy because grocery stores have a very low margin. Okay, so they're going to do the exact same thing. The profits come from the Amazon Web Services, and they'll just get bigger and bigger and bigger. Okay, so how do they do it? They get better user and customer experience. My wife loves Amazon. They invest in large upfront fixed costs. They standardize the messy, unstructured, fragmented back office functions. When I go to Penn, I have to give my demographic data to the lab. I have to give the same demographic data to radiology. I have to give the same demographic data when I get my shot. Amazon doesn't do that. One click, boom, the book comes, right? So they know how to do that. They standardize the messy, unstructured, fragmented back office functions. They're transparent and platform to distribute goods and services. So basically, just want to give you one thing, the pharmacy supply chain. I do a lot of work with pharmacy companies. Right now, okay, I'll do it myself. I take simvastatin because I'm old and my cholesterol is a little high. That's a drug that just lowers your cholesterol, okay? So some company makes that. It then goes to a wholesaler. There's then a thing called a pharmacy benefit manager, which is really weird. They have coupons and discounts. And then it goes to a pharmacy, minus CVS. Then it gets to me. That's the supply chain for drugs right now when I get my simvastatin, which is just a cholesterol-lowering drug. Amazon just bought PillPack, which provides them a pharmacy business and licenses in all 50 states. Do you think Amazon might be able to simplify that supply chain and cut out some waste? If you don't think so, you're really dumb. I mean, you know, that's, and so this, I was in Dallas last week talking to a pharmacy benefit manager. They're worried they're going to go out of business, like Kodak, because Amazon will be able to replace them. And obviously they're doing it. They just bought PillPack. PillPack is just a pharmacy that gives you the pills in a little packet for each day. But they have a license for every company. And you can do the same thing with hips, medical devices. I mean, so Amazon is going to go slow, but they've already bought Whole Foods, so they'll know everything you're eating. Blah, blah, blah. Okay, so Amazon, Berkshire Hathaway, nobody knows what's going to happen. Atal Gawande just got hired as CEO, but he has indicated he's going to be dealing with those population health things we talked about, okay? Going upstream and not worrying about so much the 10% that was hospitals and doctors and stuff. Are you with me? Big deal. Okay, so Eric Topol, this visionary, says that you could use Alexa to discuss symptoms, get feedback. You could deliver algorithms for companies to ID patients using the most care, build value-based insurance design plans, leverage telecommunication to deliver care to you everywhere, eliminate middlemen like health plans and pharmacy benefit managers. So again, people in America who are in healthcare are scared to death that they're going to, oh, it was just getting the good part. Go, go, go. So how many people here look at The Onion? It's where I get all my information. So this is The Onion. Amazon warehouses stocked with 20,000 doctors in preparation for healthcare launch. So we got 50,000 docs, nurses, and PAs. You get 5% off your next purchase with no rush option. There's a prepaid UPS label to return the doctor if you don't like them. But we can't really do anything because we just killed 4,000 GPs by a forklift. That's funny. Tough crowd, okay, tough crowd. So some deans, and like I said, I'm going to Halifax next month to talk to all the deans from all over the world about how they should change medical student education. These are some deans that have said that you need to expose students to the use of big data in decision making, how data is aggregated, analyzed, and personalized. Medical students will have to understand volume, variety, velocity, and veracity. So last slide, perfect timing. My advice, if you really want to be successful in the new world order I see coming for healthcare, you're going to have to become a lifelong learner. I graduated from medical school in 1980. There was no AIDS, never heard of it. There was no microbiome, never heard of it. There was no CAR T, never heard of it. So, you know, we didn't know the human genome when I graduated from medical school. Okay, so you have to become a lifelong learner. You've got to learn how to think critically because things are going to be changing a lot. You're going to have to learn how to partner with AI and cloud computing. And that's totally, nobody knows how to do that. Again, they're asking me. Means they don't know. You'll have to learn how to work on a team. Now that's really, Atal Gawande has said, when Kent was applying for medical school, I graduated from medical school in 1980. Why did Kent get into medical school? Because he was white, because he was smart, because he was ruthless, because he was competitive, because he was testosterone poisoned. Okay, and so we got those kind of doctors, right? We now need pit crews. We now need people that are able to function in a team where maybe the doctor's not in charge, maybe the nurse is in charge. Totally different kind of thing, okay? So that's big. I hate to say it, I think you should learn how to code. You don't have to be Mark Zuckerberg level coder, but if you're able to code just a little bit, you'll be able to understand how AI works, its good things, its bad things. My son works for Google, and he has a BA degree in political science from Carleton. But he taught himself how to code on YouTube. And now he says he's got a great job because he's not a super coder, but he's good enough. And that the coders, these engineer types, they're clueless. Think Facebook and elections. Mark Zuckerberg said, oh, we had no impact on the election. Think unintended consequences. Are you with me? So being able to think critically, and if you know how to learn how to code, big deal. Behavioral economics. You probably should read the book by Danny Kahneman, Thinking Fast and Slow, because we've learned Danny Kahneman won the Nobel Prize for behavioral economics. We now know that human beings, like us, don't always think rationally at all. And so we make decisions based on what are called heuristics, which are shortcuts, which we don't make very good decisions sometimes. So that would be good. And then I would say read a novel because of her. Because patients are going to want you to understand what they're feeling, and they're scared, and some patients just want to be told what to do. Other patients want to make all the decisions for themselves, and you need to be a good student of human nature and a good student of how humans work. And novels, in my opinion, are the best way to learn about what motivates people, what doesn't motivate people, and others. So exactly on time. I can hang around and answer questions or do whatever. You can now applaud, and those that need to leave can leave. And I hope that at least piqued your interest in terms of, and this is not bad, but it's different. And so if you are smart, you can really figure out a way to make the new healthcare world be exactly what goes to your strengths and weaknesses. But if you just plod along and say, I'm going to go to medical school, I'm going to go become this kind of doctor and not think about this stuff, this is going to turn your life upside down. It already is. And so the big thing is you're going to have to reinvent yourself over and over and over again, and sometimes people aren't very good at that. But you can be. I mean, I'm having a ball because you just have to kind of like say, what is all this stuff happening? I mean, driverless cars are coming, right? They're coming, whether you like it or not. And so what does that mean? All this stuff is coming. What is that? And nobody has the answer. I mean, I wouldn't listen to me if I were you, because who am I? I'm just some 67-year-old guy that's arrogant enough to say, this is what's going to happen. And yet my ability to predict is probably not much better than anybody else's. So be skeptical, be a critical thinker. If it doesn't make sense to you, maybe it doesn't make sense, blah, blah, blah. So if you need to go, go. If you